Thank you, everybody. It's really nice to be invited again to this wonderful ASAP community, and had the great pleasure of speaking in San Diego last year, and I'm very sorry I couldn't make it this year. I had done a lot of traveling, and I'll blame Dr. Levy for that. But I'm going to be talking today in the next 20 minutes or so about rethinking pain diagnosis and management in patients with Chiari and Syringomyelia. This is an extraordinarily complex disease, as many of you know, and we have a lot of areas that we've made some progress with, but some that we really need to continue striving to do better. So my only disclosure is I'm a huge Star Wars fan. Thank you for letting me sit in my office and give this lecture. Hopefully you can make it to Orange County sometime to see my collection. You know, when we talk about any kind of diseases, I'm a neuro-oncologist, and certainly I've seen my fair share of spinal cord associated syringomyelia. I always like to talk about those people that have influence, and that's largely politicians and celebrities. So each one of these folks on the list here have had some kind of either Chiari or, in Christopher Reeve's case, a traumatic syrinx associated with his devastating injury. And I think it's important that we realize that it's not just about the celebrities. It's about the real people like you and me that are walking the streets. This is a picture of my daughter, Amelia, who's now 14 years old, who came to the emergency room. She fell off a dollhouse in San Diego, not a dollhouse, sorry, it was like a playhouse, and hit her head. Had lots of bleeding and went to get a CAT scan, and actually my daughter has a Chiari, one, without a syrinx. And so this definitely hits home for me. I've seen many, many patients over my 20-year career here, and it's still, as of this day, is still a very controversial issue. So we're going to talk a little bit briefly about some of the symptoms associated with adult and pediatric Chiari and Syringomyelia, some of the proposed mechanisms. We'll talk into some of the research that's not even human research, which I found very interesting and not sure the ASAP group is aware of. And then we'll talk a little bit about pain, and in particular, I want to talk about the non-opioid strategy management strategies for pain. And then lastly, let's talk a little bit about science fiction and directions for the future. So in terms of just Chiari malformation, occipital headaches are a red flag symptom, back, neck, shoulder pain, cranial neuropathies, balance issues, cognitive dysfunction. And then through the development of the syrinx, among many symptoms, there could be paresthesias or numbness, tingling, weakness. And then the autonomic nervous system can be involved with symptoms such as incontinence. And when you look at pediatric Chiari malformations, the symptoms are similar. The difference is that children are not always able to express their feelings, and it's a little bit like veterinary medicine, which we'll talk a little bit about. This is the series that came from the Kaiser Permanente group of over 5,000 scans that were done in children, and about 1% of them had a Chiari, about 0.7 per 10,000. And interestingly, the majority of time, these were associated with pain that we already know, but there were 19 patients in these series that were really asymptomatic, where these scans were done for alternative reasons, such as developmental delay, seizures, or other movement disorders. So it's important to keep in mind that not everybody is symptomatic, and we really need to understand that balance of no symptoms to symptoms to be able to understand the pathophysiology of the disease. When you have syringomyelia, you can have progressive symptoms, progressive weakness in the back, shoulders, and arms, especially with the cervical region, syringomyelia, loss of pain sensation, difficulty walking. And you can have these symptoms secondary to, most commonly, a Chiari malformation, but also meningitis, spinal cord tumor, or as I said before, in Christopher Reeve's case, traumatic spinal cord injury will also give you a syrinx. And if untreated for a long time, you can have chronic pain, motor difficulties, scoliosis, among many others. And really, it's about understanding the complexities of the central nervous system, of the brain and the spinal cord. And this is just a depiction just showing the many, many different pathways that are both ascending pathways up to the brain as well as descending brain pathways. And this tiny little spinal cord carries an incredible amount of information about our position in space, pain, temperature. And so it's a very, very exquisite area with delineated nuclei or areas of signal processes. And these are also fed by blood vessels, by arteries and veins. So really understanding the complex milieu of all the cells in this region is really important to understand why a dilatation of that cord, why filling fluid, why does it affect the ascending and descending pathways the way that it does. Now, there are lots of theories about Chiari and Syringomyelia associated pain. When it comes to the Chiari, just the small posterior fossa itself, a tethered spinal cord, an instability of that joint up in the high cervical area called the atlantoaxial joint. The atlanto-occipital joints, back here, some instability. And then, as mentioned before, physical trauma and stress. Now, there are proposed mechanistic theories about this that largely have to do with the flow of the cerebral spinal fluid through the posterior fossa there. And so there's this normal equilibrium of fluid in that space. And in a patient where you have tonsillar herniation and you have resistance to that flow, there has to be increased pressure in order to get through there. And it's really that increased pressure that is very complex with regards to a less compliant dura, disorders of vascular flow. And all of this leads to what we think are the symptoms that ultimately are problems with electricity, problems with how our nerves are firing and how they are perceived by the brain. When you think about how pain works, it starts really with this deep, deep connection between the brain and the spinal cord, with both pathways that go up. Those are called afferent pathways to the brain, and then efferent pathways to the brain, back down to the spinal cord region and within areas of the brain itself. So even though the mechanical disruption is outside of the brain, it's this really complex interplay of spinal cord, ascending nerves, deep brain structures, cortical brain structures, and then back that really lead to the brain, that lead to the pain that is perceived by the brain. So what I found fascinating is there is a breed of dog called Cavalier King Charles Spaniel. I've probably seen one on the street. Now I'm going to start looking for them because this is a particularly interesting breed. And because of the neuroanatomy of these canines, they often have acquired Chiari malformations and subsequent syringomyelia. And why this is very important is that not only does this research really allow us to understand this in humans, but also there are lots of areas of research that I'll show you with regards to some of these connectivity pathways. And then furthermore, really understanding pain in these animals and how they treat. So often we talk about research in medicine where we use rodents, we use mice, we use rats. Animal models are very hard to come by. Sometimes there are other animal models that we use, such as sheep or sometimes horses. But really, this is something that has been well studied for decades. And in my recommendation, if you haven't had one already, maybe consider having a veterinarian who has expertise in this area, who's actually doing research, invited to one of the ASAP conferences. I think that would be an interesting perspective. Now, looking at this, some of the work, not only understanding by imaging, and I'll go back a little bit. This is a normal canine right here, but then you can see here's a canine with a Chiari malformation without a syrinx, and then here is a very prominent Chiari malformation with a very extensive holochord syrinx. So this is really the perfect animal model to study, because not all of them develop it, but they develop it with a very high frequency. And there's a very high frequency of pain associated with these. And really understanding how the dogs manage the pain could be critically important to research in this area. Along the same line with the canine research, they've found that you can look in a model here. This is an example of a Chiari with associated syrinx. And you can really do deep level integrated analysis using MRI. So here's MRI. You can use fancy diffusion tractography, just looking at some of those pathways. You can look at the volume, the actual volume of the brain, and what we call the white matter. And what they really found is that these animals that have chronic Chiari with syrinx, they actually have physical changes on their MRI. You can see that the volume of the gray matter, and the gray matter is the area on the brain where the nerve cell bodies live, it's actually less. The volume is less, in particular in an area called the cingulate gyrus, which is right below an area called the corpus callosum. And so this is just fascinating that we understand what the secondary effects of pain are on the brain from these animals. And not only that, but we understand what the changes are at the spinal cord level in patients that have syringomyelia. And then they can have signs of phantom scratching because of pain. And so just doing a quick literature search on PubMed, there are over 200 publications of canine models of Chiari and syringomyelia, most commonly in this King Charles Spaniels. But this is definitely an area that's worthy of future research, because essentially what we want to stay away from is we want to stay away from opioids. And we're learning the negative effects of opioids, not just patient by patient, but really just in society as well too. And we're really not treating the underlying mechanism of injury. We're trying to interfere with some of these very complex pathways. So what are some of the non-opioid medical management options? Well, we're using some of our anti-seizure therapies, steroids, NMDA receptor antagonists, anesthetics, nerve blocks, scalp blocks, and neuromuscular blockade. All of these are being used. Now, as I had said before, I think that there may be something we can learn from our canine friends, and this is just a list of medications that are used in the clinical management of Chiari-like malformation and syringomyelia in dogs. And you'll see many of these medications that are listed are actually some that I showed you on the previous slide. And not only that, but this is a perfect model system for us to be able to use additional newer agents that are not yet tested safe in humans. Now, what are some of the mechanisms of associated pain? We talked a little bit about the pressure effects, but also there's effects based on abnormal neuronal transmission. And this is really where we're getting at in terms of using some of our anesthetic agents, some of our antidepressant agents, and some of our anticonvulsants, is we're really trying to affect the flow of ions across these nerve cell membranes so that we can decrease some of those signals that are leading to pain. But we know that it's a very complicated connectivity between all of these. This is just a review study looking at some of the articles that have been shown to be effective in patients with Chiari and symptomatic syringohydromyelia. And again, this ranges all the way from surgical management to oral drugs that decrease the spinal fluid production, anticonvulsive therapies that block some of those neurotransmissions, and other injectable therapies such as botulinum toxins and other anesthetic blockades. And so in general, these are largely the categories that are being used. And then we'll talk about cannabinoids in a minute. What's really important is trying to differentiate the cause of pain due to alternative diagnoses. And given the high incidence of Chiari's, it can be very difficult for clinicians sometimes. And I talked a little bit about veterinary medicine and how kids often don't say enough. Well, I think on the adult side, it really gets to be very complex when you have an adult who may have other comorbid conditions, and some of those conditions may overlap with the pain associated with this condition. So it's not a clean system. Now, what we have learned, and I'm going to talk a little bit about non-medication therapies, is I do believe there really is a role for alternative therapies in the pain management of patients. I'm so happy that acupuncture is starting to gain some momentum in this country. My wife is actually an unemployed acupuncturist, largely due to poor insurance reimbursement, and my 4-year-old doesn't help either. But this is a proven science. This has been around for thousands of years. And I mean, this is just an example of a trial that looked at acupuncture for chronic neck pain, just showing the incredible amount of patients that had symptom improvement. So I do highly recommend this modality. I'm afraid of needles too. I just got my blood drawn yesterday, but these needles, you can barely see them and barely feel them. So I highly recommend that. The other thing that we're really coming to grips with is that there are natural substances on this earth that also can help with some of these pathways. And I think cannabinoids are one of them. It's not only about the CBD that has now been used for epilepsy and some of our other disorders, but also THC and some of the many other compounds that is an avid area of research, and we really don't understand the majority of these compounds. Many of them have not even been isolated yet. So I do think there's a lot of promise in that. I do think there's a lot of promise in the role of yoga and meditation in associated pain. And we know that people that do meditation, or Buddhist monks, they have very different brain waves when we look at EEGs on them, when we look at SPECT scans on them, looking at blood flow. There's just something about meditation, that was a slip, that really can help with some of these pathways. And then as we think ahead, what are some of the areas that are worthy of exploration? One of them is an area called neuromodulation. Now, our brains are batteries. They're synchronous discharges of neurons. How can we adjust the frequency of these neurons that instead of giving a drug, we give, let's say, for instance, transcranial magnetic stimulation? And this has been FDA approved for depression in the United States, and there are many other areas, including pain, that this is being actively studied. How does this work? Well, this works by changing the neuronal frequencies, and then essentially it inhibits some of these deeper pathways that are involved in pain. We call this the thalamocortical signaling pathways. And this is the cortex, this is your sensory cortex up here, where those nerve cell bodies live that are the receivers of those pain. Now, another thing that we're doing a lot of here at Children's Hospital Orange County is deep brain stimulation for children with movement disorders and with spasticity. However, I do believe that not only stimulating surface neuronal activity, but if we're able to put electrodes and stimulate some of those deep pathways that we know are involved in pain, that may be another area too that's worthy of investigation. There was one abstract that was reported about 7 years ago treating a patient with Chiari malformation and Syringomyelia with regards to tremor. And so what I think we need to do is we need to look at these technologies, as invasive as they are, for those cases of refractory pain associated with this patient population. And then again, differentiating the cause and effect in a very common disorder is something that we need to learn. And I do believe that learning from our canine friends can help us to get there. The other problem is when we're doing clinical trials, really understanding the power of the placebo and then the power of the nocebo. So placebo effects are perceived benefits of taking essentially a sugar pill, while a nocebo is actually perceived worsening benefits, worsening symptoms. And we know in neurology, for instance, the placebo rate for a new headache medication is about 30%. So you could give a patient a sugar pill and with a chronic headache, and they will say that the pain improves 30% of the time. And I think really what this ultimately is what I was talking before, this internal ability to be able to change some of these neuronal pathways and neuronal signal firing. And I think that that's really another area that's non-pharmacology, non-drug that we really need to look into. And we know that placebo effect is very, very strong when it comes to any kind of clinical trial, especially chronic pain. And it's really understanding this combined model of how the placebo works. If we could tap into that and understand the nature of that placebo effect, we could potentially amplify that, lower the need for pharmacology so that we can adequately treat our patients with this very, very complex disorder. And it's complicated. This whole pathway between nocebo, placebo, what are the different areas of the brain that are activated? What are the areas that are inhibited? It's this complex milieu that ultimately we're all striving for in terms of a therapeutic outcome. And again, coming back to these slides, because I think it's really important that we understand the complexities here of the circuitry of the brain, the deep connections, these pathways that we're really not able to see by neuroimaging yet. Taking an MRI is a very crude way, and it doesn't give us any idea about the biology, what is going on at the cellular level with these pathways. And again, I think this is where animal models can be critically important. And we know, as I showed you before in the canine models, there are demonstrated changes of the MRI of the brain in patients with chronic pain. You can see volume loss in different areas of the brain. But think about this, there are areas of the brain that are affected that we can't see by MRI. And I think that's really what we need to understand to move this field forward, is understanding the connectivity models of this complex disease. And lastly, the value of clinical trials. I really, as a neuro-oncologist, as a scientist, I believe that clinical trials, if they're well done, really inform us in terms of therapeutic modalities. If everybody is doing something different, we are never going to find a cure. We're not going to achieve our outcome. And the model that I like to use is the leukemia model, where leukemia in children was a death sentence in the 70s and 80s, and through collaborative clinical trials, where people are trying to build upon the effects of successful chemotherapy, leukemia is now 90+% curable. So I think we have to take that same teamwork approach as we move forward to this disorder. And there are clinical trials. I urge people to go to clinicaltrials.gov. These are new trials from the last time that I presented to you. There are injectable therapies, there are cellular-based therapies, old drugs like thalidomide. Some of these are in China, some of these are in Europe, some of these are in the United States. But really, our goal should be to find a cure for this that is non-pharmacology related, because I think that this is a large problem in our society, and I think that we can definitely find alternative pathways. I know I talked very fast, but thank you very, very much for your time. This was an honor to be here. Thank you, Dr. Grant.